I'm Andrew Khoo. I'm a private psychiatrist who has been involved with treating people with PTSD in the military, after the military, and also in the emergency services for about the last 18 years. I'm passionate about making a difference and hopefully seeing one day that we can quickly pick up people with PTSD in the military and return them to their substantive positions, doing everything they were doing before they got unwell. The best estimation of the prevalence of PTSD in the Australian public comes from an ABS survey that was done in 2009. This estimated the PTSD prevalence, and that would be point prevalence, at 6.4%, which actually made it the most common mental disorder in the Australian population. It is generally thought, however, that we probably overestimated its prevalence, and probably because of the questions that we asked. So if we look at similar populations in the US and the UK, we're looking at more like 5% in the general population. And this might seem low, but it is low because a lot of the general population of Australia, so we're talking about 40%, have never experienced a trauma sufficient to cause PTSD. If we look at traumatised populations and then how many of them go on and get PTSD, that's a much more relevant statistic. And a typical population like this is the veteran population who've been deployed and potentially traumatised. In these populations, we find a prevalence at any one time of somewhere around 10% with PTSD, but a lifetime prevalence for these people of up to 20%. Well, there are different kinds of trauma, and PTSD is a very individual response depending on an individual's response to the trauma. However, PTSD is PTSD, defined by the diagnostic criteria that we are currently limited to. Okay, and that is the criteria from DSM. If you look at PTSD from a military point of view, it's absolutely acceptable and a fairly homogeneous presentation in terms of symptoms and signs. We also have people talk about types of complex PTSD, which seems to result from people who have childhood trauma. But this type of PTSD manifests different phenotypically from classical PTSD and tends to present more along the lines of a borderline personality disorder. So in the last few years, we've had to move from DSM-4 TR to the new diagnostic system of DSM-5. Okay, and this has meant some changes in the PTSD diagnosis. Unfortunately, of all the diagnoses, PTSD seems to be one that changes consistently every time there's a new edition of the diagnostic manuals. And this is because PTSD is the one disorder in mental health that tends to attract a lot of court time. And this is because usually there's an event that's caused the illness, and that event can then usually be attributed to blaming somebody. And if you can blame somebody, you can sue somebody. And so therefore, PTSD clogs the courts. And if PTSD clogs the courts, then we have people called lawyers who are very good wordsmiths who tend to try and bring more people under the PTSD diagnostic banner. So we've got to keep tightening up the diagnosis. Now, unfortunately, legally, when we tighten a diagnosis, we don't make less words, we add more words. And so the changes from DSM-4 to DSM-5 really revolve around the precipitating trauma. And what's been added in DSM-5 is sexual assault. Okay, previously it was thought that that was not a life-threatening disorder, but sexual assault has been added specifically to something that can cause PTSD, which is very appropriate. And the second thing that's been added is people who are consistently and repetitively exposed to death or human suffering. Okay, and these are people like crime scene investigators, firefighters who have to cut people out of cars, police arriving on scenes, and that's very appropriate as well. The only other major change in the criteria is there used to be 4 sets of symptoms to diagnose PTSD. The re-experience or the trauma, first of all, you have to undergo trauma, the re-experiencing symptoms, the avoidance symptoms, and then the anxiety symptoms. They have added now depressive symptoms, and I think that's very appropriate as well. I guess now what we're doing is we're talking about the typical presentation of someone with PTSD, or the typical first presentation of someone with PTSD. And GPs will know that often they don't present with the psychological symptoms themselves, and this is usually because of personal stigma about mental illness that they have, or the cultural stigma that comes from being in the military for a long time against mental illness. And we usually find that this military type stigma is more powerful than the stigma against mental health that even exists in the general community. So often they can present with physical symptoms: chronic pain, tinnitus, irritable bowel, tension headaches, these kind of things. And GPs will be very au fait with people with psychological conditions presenting with physical symptoms. The next thing is the typical types of psychological symptoms that these people are going to be presenting with, or people with PTSD will present with, are things like insomnia, agitation, irritability, impatience, intolerance, poor anger control, nightmares, relationship problems, and substance misuse. I think when somebody comes into your room and you can establish pretty quickly that they've had a job that's going to have led to exposure to significant trauma, that you need to be aware that PTSD could be lurking in the background. So if you can join the dots between exposure to some kind of trauma and some of those sort of softer non-diagnostic symptoms that we just described, then you're a good way along to identifying a PTSD. With all the available evidence we have worldwide, what we've found is that the most effective form of treatment that we know of currently, first of all, is psychological treatments, okay? Not pharmacology, okay? Not to do with medications, but psychological treatments. And of all the psychological treatments, the best treatment at this stage, or the best evidence we have, is that cognitive behavioural therapy tends to be the best. And within cognitive behavioural therapy, a trauma-focused approach is seen as the best or the gold standard treatment currently. We need to be aware that the current evidence says that the power of medications to decrease the core symptoms of PTSD is overall pretty poor. We seem to be at a position well behind where we are compared to even other psychiatric conditions like depression, schizophrenia, bipolar, etc. We're further along the way with pharmacological management. But there doesn't seem to be any real specific medication or silver bullet, if you like, medication-wise for PTSD. So where does it fit in? Well, my feeling about where medication rests is controlling symptoms enough so that people could take on the treatments that we know have the most powerful evidence, which is psychological treatments. So the symptoms that we can control with medications that will help people uptake psychological treatments like CBT are managing sleep, so helping them be able to sleep, hopefully without getting them addicted on any sleeping medications, controlling their anxiety and their depressive symptoms enough so that they can sit in a room with their therapist and take stuff on board and be able to do homework. And managing anger is probably the last thing that we can do a little bit pharmacologically as well. Okay, so the first thing is, I think, just having an idea that this condition, it seems to be building in prevalence in the Australian community and really is a significant thing that we need to take aware of and specifically look for, particularly in populations that have been traumatised, because we know that early intervention in PTSD leads to better outcomes. So just being aware is the first thing. The second thing is really being able to engage with patients with PTSD. So really working on the therapeutic engagement and rapport. And this is important because a lot of people with PTSD don't trust. And if we look at a veteran population, these people find it difficult after being institutionalized in the military in really interacting with civilians. So we really need to learn a little bit about military culture, a little bit about what is important for veterans. So things like compensation, okay, and the whole procedures around treatment and compensation following their military careers, and also being aware of the almost inevitable outcomes for a lot of these that involve problems domestically, maritally, financially, vocationally, compensation-wise, as I said, and even from an accommodation point of view. So all these problems just tend to be in the typical mix for a young soldier with PTSD. The next thing we need to remember is medication, like I said before, in that, use medication to control symptoms so that people can take on that psychological therapy. Certainly also, early referral on to specialist services is really important. And I don't just mean specialists like psychiatrists. What I mean is places like veterans and veterans' families counselling service that specialise in this area, clinical psychologists, psychiatrists, etc.